Hello, welcome everybody. Thank you for being here. Before we get started, I want to do some quick housekeeping. This event is being recorded and the recording will be posted online afterward. Speaker biographies are available online at urban.org and a link to the bios will be posted in the chat. We have closed captions turned on, but if you'd like to change that, you can click on the live transcription button at the bottom of your screen. All participants are muted, but you can send questions or comments in the Q&A box at the bottom of your screen at any time, and we do hope to have enough time for audience Q&A at the end. And finally, if you tweet about the event, please tweet using the hashtag #live@urban. Okay, so thank you again, everyone, for joining us. I am Heather Hahn, a senior fellow in the Urban Institute's Center on Labor, Human Services, and Population. We are very excited for the two panel discussions we're about to have on the timely and challenging questions of how state responses to the pandemic might affect safety net programs and the people who count on them. This is the topic of two Urban Institute publications released today. The first has a title very similar to this event, which is How Might State Responses to the Pandemic Affect the Safety Net? It examines food assistance, housing, cash assistance, childcare, and healthcare, and how they responded to COVID-19 in 2020, and what the outlook is for these supports in the next year. The second report is How Might State Medicaid and other health programs be affected in the pandemic's aftermath? This one takes a deeper dive into Medicaid and other health programs, including mental health, substance use treatment, public health, and maternal and child health. This report examines how these programs responded to the needs that arose in 2020 during the pandemic, and once again, how they might be affected in 2021 and beyond. Our conversation this afternoon will explore the circumstances that states faced and are facing, the actions they're taking to mitigate the immense harm of the pandemic, and the challenges and opportunities that remain. As we all know, in the United States, more than 500,000 people have died from COVID-19. Among the survivors, millions of people have lost their jobs or had their hours cut, are behind on rent and utility payments, and don't consistently have enough food to eat. Many parents have been unable to find safe, affordable childcare, which has had a major impact on their ability to work. And social distancing and fears of contracting the virus have also disrupted access to healthcare, and massive job losses have disrupted health insurance coverage for millions. Many of these hardships and economic impacts were predicted when it became clear that the pandemic would require shutting down large sectors of our economy for extended periods. But interestingly, many of the early predictions of how the pandemic would affect society have not come true, as we will discuss today. Not all states have experienced the same level of economic hardship. Certain economic sectors and types of jobs have suffered more than others. People who worked in low-wage jobs before the pandemic have been most vulnerable to further economic adversity during the pandemic, while people with higher incomes have largely been insulated from the worst economic effects. But one thing is crystal clear: the financial and health burdens have fallen disproportionately on Black, Latinx, and American Indian people, reflecting longstanding racial and ethnic disparities that stem from systemic racism and discrimination. As dire as the situation has been, we now have seen that states took bold action during 2020 to protect and serve the people that rely on their support, and states showed considerable ingenuity and creativity in their responses. States are on the front lines of helping people access federal and state supports for food, housing, cash, childcare, and healthcare, among others. And these safety net programs can help people weather the economic crisis by providing stability and helping them meet basic needs when they earn low wages or are out of work. The federal government, too, played a massive role in mitigating harm, infusing roughly $5.5 trillion into the economy over the past year through individual payments, payments to businesses, enhanced unemployment benefits, support for a range of health programs and activities, as well as direct aid to state and local and tribal governments. And now, following passage of the American Rescue Plan and a ramp up in vaccinations, state legislators and program administrators face continuing crucial questions about how to bolster their safety net programs. including how can they bolster components of the safety net that came up short during the pandemic? How can they target the large temporary influx of federal relief funds to have the greatest effect? How can they address the stark racial and ethnic inequities that were laid bare during the pandemic? And how might they re-envision their programs so they're more nimble and better prepared for the next emergency? These are all the questions we're going to be exploring today. In a moment, I'll turn things over to my colleague Ian Hill, a senior fellow in the Urban Institute's Health Policy Center. Ian is going to moderate a discussion among three stellar panelists, whom he will introduce, who are joining us from states across the country where they've been dealing with these issues firsthand for the past year. They'll have 30 minutes of discussion, and then the panelists will respond to questions from you for another 10 minutes. So you're going to remain muted, but please use the Q&A box to submit questions, and you may submit those questions at any time. After that, we'll turn to our second 30-minute discussion, which I will moderate among three equally stellar panelists from national associations representing Medicaid directors, other state human service administrators, and budget officers. They're going to reflect on what we hear during the state panel and offer their own perspectives from the national level. You will again have an opportunity to pose questions to these panelists through the Q&A box. Ian, your turn.
Okay, thank you, Heather. Thanks very much, and welcome to everyone. As Heather said, when we were designing this event, we thought it would be really important to first hear from state officials, to have them tell us about their experiences over the past year and then what lies ahead in 2021. And I am delighted to introduce to you all the state officials who've been gracious enough to join us today. Suzanne Bierman is the administrator of the Division of Healthcare Financing and Policy in the Nevada Department of Health and Human Services. In other words, she is the Medicaid director. Ms. Bierman has worked in Medicaid in other parts of the country as well, where she was for example, the assistant director of Medicaid in the state of Arkansas. Our second panelist is Danette Smith. Danette was appointed the Chief Executive Officer of the Department of Health and Human Services in the state of Nebraska in early 2019. She brings more than 25 years of executive leadership experience in large organizations at both the state and local levels, including serving as director of the Virginia Beach Department of Human Services, and also in the cities of Seattle, Atlanta, Charlotte, and in Cook County, Illinois. And then finally, Renita Polk is a principal consultant with the Senate Committee on Budget and Fiscal Review in the state of California, the California State Legislature. She's been with the committee since 2017, and on the committee, Renita oversees human services issues, such as social services, developmental services, and aging issues. Welcome to you all. Let's get started with a couple of questions that kind of look back in time and where we can focus on the year behind us. I'd like to ask you to tell us all about some of the biggest issues and concerns that you faced in the early months of the pandemic. Suzanne, why don't we start with you? When the pandemic first started, what parts of Nevada's Medicaid program commanded your attention the most, and why? Was it the long-term care crisis? Was it fears of eligibility and large enrollment increases? Was it keeping providers solvent? What got your attention?
Well, first, thank you for the opportunity to participate in this panel today and to be able to reflect on some of these issues and talk about what we see going forward. So first and foremost, looking at Medicaid as a health insurer, one of our initial issues of focus was taking full advantage of opportunities to promote coverage and access. There's never a good time to be without health insurance, and that's particularly true in the time of a global pandemic. So we were really focused on making sure that we were providing coverage to as many Nevadans as possible. And for example, took up the optional COVID-19 uninsured group. That was an option from the Center for Medicare and Medicaid Services. So early on, really focusing on making sure that we were providing as broad-based coverage as possible, and also ensuring that our program was able to be more nimble than it often is, and that we took full advantage of federal flexibilities. And our federal partners at the Centers for Medicare and Medicaid Services really helped us identify those early on through a number of disaster state plan amendments and 1135 waivers, not to get too deep in the Medicaid weaves, but really opportunities to do things like ensure programmatic flexibilities around provider enrollment, making sure that early refills of prescription drugs were available, expanding telehealth, a number of programmatic changes that were really key and crucial to making sure that we could continue to provide coverage at the same time we were trying to promote social distancing. So that was a lot of our early focus. Certainly long-term care services and supports, Medicaid does provide those services and cover those in ways that commercial insurance doesn't. So we're really focused on supporting long-term care services and home and community-based services. And there were some additional flexibilities from CMS that helped us do that as well. Also wanting to make sure that our providers were aware of things like the Provider Relief Fund. That was a part of the CARES Act. So spending a lot of our early time on outreach and education related to some of those federal funding opportunities, and also as an employer ourselves, working with our workforce to really transition pretty quickly to a remote work environment, again to promote social distancing and making sure that our workforce was safe and still available and able to provide these critical services to Nevadans. So there was a lot, and it was really inspiring to see our workforce come together and handle tremendous change quickly and adeptly on a number of different fronts.
Nice, thank you. A busy year. Danette, how about you? What programs were of biggest concern in the Nebraska Department of Health and Human Services?
Thank you so much, Ian, for having me on. And I'm really ecstatic to be joined today by Renita and also with Suzanne. I know in Nebraska, we focused on a couple of things very immediately. One was really looking at our child care programs and looking at how we could implement waivers that allowed our families to be able to access child care during the pandemic with some flexibilities. And also allowing some flexibilities to our providers during the emergency. We also looked at ways in which to provide opportunities for our licensed child care providers to build DHHS, that's my department, the Department of Health and Human Services, for the days that a child received subsidy but would be absent. We were trying desperately in Nebraska as much as we could to keep as many of our licensed facilities, our home care facilities open as much as we can for those parents that needed to access childcare and could work, that they would be able to do so. When we turn and kind of pivot and look at foster care, with our foster care families, we really tried to look at visitation. Here in Nebraska, we put visitation on hold for approximately 6 weeks. And the reason why we did that was because we wanted to ensure that we had PPE for all of our providers. Believe it or not, we went out, we made sure that all of our providers had the necessary PPE, not only to be able to work safely, but to also be able to support the families that they would be able to interact with. We also, on the child welfare division, we adjusted our case rate. Rather than doing per service rate, we pivoted to doing a reimbursement rate. That allowed us to do, or our providers to do more virtual childcare programs. Finally, I have to mention this because under my direction is public health. And so I can't tell you that the majority of my time was spent looking at and preparing and getting through the pandemic. We spent a lot of time in those early days with our long-term care facilities, with our health systems throughout Nebraska, not only analyzing data, but showing us what is the data telling us about the rate of persons being affected or testing positive, what the hospital care needed to be, how many people we were seeing in the hospitals and our ICUs, and then also looking at how then we transition them into long-term care facilities and also into our assisted living. So right up front, we were dealing with our seniors, and then we were also dealing with the children and families of Nebraska.
Okay, the full age range. Renita, tell us about the early months of the pandemic. for you. What did you anticipate as the senior budget analyst, and how bad did you think things would get in California?
Yeah, well, first off, I just want to say thank you for having me and inviting me to participate on this panel. I'm really happy to be here and excited to hear what the other panelists have to say. But I think in the early days here in California, you know, I'm sure as it was everywhere else, you know, no one really knew what to expect. And here in California, I think there was a lot of fear that we would see a repeat of 2009, when the recession back in 2009, and we had to make quite a few cuts to a lot of our health and human services programs here in California. And so I think there was a lot of fear that we would see a repeat of that. Thankfully, we did not. But so at the beginning, a lot of my time was spent connecting with, for example, what would be Danette and Suzanne's counterparts here in California, and talking to them and trying to figure out what the need is, where we're seeing the biggest need, and how, you know, as I work in the budget committee, where can we put funding that would help address the largest need in the various health and human services programs across the state.
Okay, terrific. Thank you so much. I am going to, let's shift gears now. So we got a kind of a quick look back at the year past. Let's look forward now and have the rest of our questions really focus on what you think might lie ahead. And I guess I'd like to have each of you tell us more about the challenges you see both in the immediate future and then the program areas that you think will consume most of your attention in the coming year. Danette, would you like to lead off with that one?
Sure, no problem. I think that what is going to take a lot of my attention is, as I started off earlier, is really looking at how we strengthen our public health system here in Nebraska. I think that we have done an excellent job with making sure that, number one, we got as many Nebraskans tested, but now that we're pivoting to vaccinations, that we're making sure that we're getting Nebraskans vaccinated. But I also think one of the things that we'll be looking forward to in the future is really looking at an agenda around health disparities, not only in our most urban areas, but also how do we serve both the rural and panhandle communities here in Nebraska. And that's going to take some working with our community providers, our health systems, our local public health departments, and our FQHCs. And so I'm looking forward to that. The second thing around public health is really looking at our IT solutions. One of the things that the pandemic pointed to was data, and you've got to have very good data to be able to then transpose that into good programming within Nebraska. And we know that data really helps support the work that we do. When I look at some of our other programs, I know that one of the things that I'm having conversations with all of my division directors is how do we stand up childcare programs for persons with disabilities, behavioral health, child welfare in a way that prepares us to pivot into a future state in the next 2 to 3 years. I've asked all of my division directors to look at, if this were to happen to us again, what are the strategies, the supports, the staffing that we need to have in place to be able to help us prepare for the next 2 to 3 years. And so that's what we're doing with the focus on childcare, a focus on our SNAP programs and any of our eligibility programs, making sure that anything that we provide to children and families has an ability to move that family and certainly support the state in being able to do that work well. As you know, we're using our FMAP dollars to help us look at how we undergird and support our providers, not only with our long-term care facilities and assisted living facilities, but for some of our community-based programs with our developmental disabilities. So that's what the future is holding here in Nebraska. We are being strategic. We're being intentional about what our future can look like. And so we're guiding our program development in that arena.
Excellent, excellent. Thank you, Danette. Suzanne, let's go to you. What aspects of the Medicaid program will be presenting big challenges to you? We know that the public health emergency may be lifted at some point, at which point you'll have to deal with the issue of redetermining eligibility for your beneficiaries. We've heard a ton about transitioning long-term care services and supports to the community. We heard a lot about provider solvency issues in Medicaid as we did our research. What's grabbing your attention? Where will you be focused?
Thanks for the question. And I think you hit on a lot of those points, but as was mentioned in the introductory comments, not all states have had the same sort of budgetary impact from COVID, and Nevada, given the unique nature of the state's economy, very heavily reliant on gaming and entertainment revenue, has been hit quite hard. And I think it's just really focusing on the economic recovery and Medicaid's caseload and trying to budget through a lot of uncertainty has been the case for us. And I think, to some extent still remains so for the upcoming biennium. So here in Nevada, we have seen a really unprecedented increase in our caseload, which again, I think it's critically important that we're able to provide health insurance to Nevadans, but we're now covering about 25% of the state's population. And that is almost a 25% increase during the COVID public health emergency. So certainly there will be a tremendous amount of work to be done when the public health emergency is lifted related to redeterminations, and the enhanced FMAP will then not be available at that time. So really trying to manage through some of those budgetary uncertainties and continuing to provide coverage for Nevadans in need.
Just how much did the program enrollment grow during the year? Where were you before, if you're at 25% of the state population now?
Yeah, so for Medicaid caseload, March 2020, we had a caseload of about 645,000, and for March of 21, we were up to 801,000. So that's the highest our Medicaid caseload has ever been, and is about a 25% increase over that time period.
So your Medicaid expansion provisions really help.
Oh, absolutely.
The residents of Nevada.
About 10% of the state's population has coverage now as part of that newly eligible adult group. So just indispensable in terms of keeping Nevadans covered.
Great. And let's turn to our budget official. I'm going to combine a question here for you, Renita, that is forward-looking and also has to do with the new federal dollars. When we were interviewing folks for our papers, it was very early in 2021, and the biggest concern we heard over and over from state and national officials was, would there be additional federal funds that would continue to bolster states, and how that variable turned out would be critical in determining how states would do in 2021. Well, a couple months later, the American Rescue Plan answered that question, right? $350 billion were targeted to state and local and tribal governments in continued relief. So I'd love to hear you talk about, Renita, kind of what the year ahead has in store for you. Governor Newsom's budget was released in January. You guys are in the heat of trying to figure out your balance your budget and with your legislative agenda and goals. What are you going to do how are you going to spend these federal dollars with regard to health and human services?
Yeah, so we are, like you said, we're right in the middle of that process and having those discussions. The state fiscal year begins on July 1st. And so according to the state constitution, we have to have a budget completed by June 15th. So we're having those conversations now. I think kind of one of the biggest kind of challenges and things in the immediate future as we're having these budget conversations is trying to balance one-time spending versus ongoing spending. It's especially because we have a revenue surplus and a large influx of federal funding coming in this year. But in the future years, we're expecting to see a drop off in revenue, and so we're not always going to have the surplus. So it's trying to think about budget investments that we can make this year that are one time, but also thinking about the future and trying to build up reserves to prepare for potential deficits in the future. And in terms of spending the incoming federal funds, like I mentioned, we're still having those discussions, but there are some priorities that we are thinking about and hope to use that funding for. And two ones that come to mind right now are particularly food security. And this has been a big issue here in California, and I'm sure in everywhere else. But we made quite a few investments in last year's budget, and we're thinking about including those in this year's budget as well, to provide one-time funding for food banks, and also to provide additional funding for several different food assistance programs within the state to address that need. And in particular, when it comes to seniors in California, those folks, of course, we all know that are most vulnerable for COVID. And even though we have vaccines now and we're starting, I guess, to see the light at the end of the tunnel, we are still seeing a lot of food insecurity among our seniors. And so trying to shore up those programs that serve our most vulnerable Californians.
You talked about near-term and then longer-term funding. Do the federal dollars provide enough flexibility for you to carry them over very far into the future? What are the constraints there?
That is a good question.
Okay.
Yeah, we're still kind of in the process of learning more about kind of what the federal funds can and can't be used for. So that's kind of, we're in the middle of getting answers to those questions right now. So unfortunately, I don't think I have an answer to that question at this moment.
Sure. Well, I'm sure we all agree that these are precious monies and we want to spend them right and not spend them inefficiently in a rush to just get them out the door. Danette, same question to you. How is Nebraska planning to distribute the influx of federal funding? What are you guys looking at?
Yeah, as always, we're excited about the opportunity to have the monies. We certainly are wanting to utilize them in a couple of different ways. As Renita spoke earlier, we are seeing the same thing here in Nebraska about food insecurities. We, during the pandemic, worked very closely with our two large food bank entities here in the state to make sure that we were funding them for any food insecurities that we were seeing across the state, and that went very well. We saw a significant increase in the number of individuals that were actually coming to our local food pantries and food banks for services. We also saw an increase in the number of commodities that were being bought by our food banks. And so we were happy to be able to fund them for those issues as well. I know that we will continue to provide support to those homeless shelters and to continue to provide housing relief where we can. We did a lot of work during the pandemic around making sure that eviction strategies were actually not happening and that we were allowing people to stay in their homes. And Nebraska will continue to work with our housing areas here in Nebraska to make sure that we keep people housed, we keep people with food so that they're able to take care of themselves as we make that transition back to normalcy. When I think about the three top priorities that Nebraska is going to be doing moving forward with some of the new influx of money, number one is really bolstering up childcare. Childcare is one of those strategies that help parents get back to work. And so we want to look at constructive ways to be able to use those dollars to do that, not only from a workforce development for childcare providers, but workforce development, looking at bolstering programs and making sure we're providing the right support to parents. The second one is really looking at supports to our developmental disabilities community, really being creative in terms of how we use some of our FMAP dollars for some of our providers, strongly looking at how we utilize those dollars to help us with some of our community-based programs, because as you know, many of our clients were in residential facilities and we're not able to get out in the community as we as we need them to and as they want to. And so we want to make sure that we're able to do that. And then the third thing is really looking at how we bolster behavioral health. We are very concerned here in Nebraska about suicide and persons experiencing isolation. And so as we get SAMHSA dollars in, we're going to be looking at creative ways to continue telehealth as a way to help people seek mental health treatment, but also where possible to get them back out in the community. What does that look like from a state perspective and from a local perspective in terms of helping our citizens return back to normalcy? So those are some of the things that we're looking at. We're happy for the dollars. We are also, again, receiving substantial dollars on our public health, and we're going to be using those dollars with public health to kind of re-engineer and retool our infrastructure, from data to IT solutions, to testing, to surveillance. We're going to make sure that if this happens to us again, as best we can, we want to use these dollars to help us stand up and be prepared.
Thank you, Danette. We heard from quite a few public health officials that, you know, the attention focuses on public health when there's an emergency, but once the emergency's passed, then everyone looks the other way, and further investments in kind of public health infrastructure often wane. So it's interesting to hear that that might be one of your priorities. Very good. I want to move ahead now to the topic of racial and ethnic inequity. This is a longstanding structural and societal problem in our nation. It pre-existed the pandemic, but inequities have been further laid bare and exacerbated by COVID-19. So I'd like for each of you to tell us a little bit about how your state might address these issues. I think I'll start off with you, Suzanne. What's going on in Nevada in an effort to address racial and ethnic inequity? I understand that during the past special session last summer, your governor declared that structural racism was a public health emergency. So I'm curious as to whether that has spurred some action.
Great. Thanks for the question. And yes, that is accurate. Our Governor Sisolak did declare systemic racism a public health crisis during the special session that we just had this summer. And there are quite a few initiatives underway to try to address some of those longstanding challenges. One, again, as a large employer, Medicaid is part of the umbrella Health and Human Services organization in Nevada. So kind of as an employer, there are a lot of things going on within the department. We have an Office of Minority Health and Equity, and our department has recently taken specific steps to address these issues in the workplace, has convened a cross-agency work group, and has established a diversity and inclusion committee, fielded a climate survey, which has had a really high response rate, which is quite encouraging. We're going to be continuing to have focus groups and town hall meetings to really facilitate these conversations around how we can do better as an employer. Also, just as the Medicaid program, we've been spending time trying to communicate the value of the Medicaid program itself in terms of helping to address these longstanding inequities. When you look at participation in the Medicaid program, certain populations participate at higher rates. And I think we had a recent statistic that the African-American population in Nevada is about 9% of the overall state population, but 54 to 58%, depending on the month of the data pool, that percentage of the African-American population has Medicaid as their insurance provider. So just really focusing attention on the impact of programmatic decisions related to Medicaid as a health insurer for low-income populations. It's been one of our messages. Also, I think someone mentioned earlier the importance of data collection. So really working on that and thinking about, you know, best practices and how you measure even across multiple data sources and agencies. Have been involved in a couple multi-state conversations around some of those best practices related to improving data collection. Also, again, kind of from the Medicaid perspective, one of our biggest levers generally in terms of changing policy is through our managed care procurement. And we do serve about 75% of our participants through managed care organizations. So we've just put our managed care contracts out to bid and really focused on what we can do to address these issues via that procurement, looking at things like stratifying data reporting, really adding some specificity to cultural competency plans that we require of the managed care organizations, and also focusing on the performance improvement projects, having this as a particular area of focus. So really trying to think of it from multiple different lenses, you know, as an employer to as a large purchaser of healthcare, and trying to leverage every opportunity that we have to improve and address these issues.
Thank you, Suzanne. Renita, how about from a budget perspective? How might California spend or reallocate resources to help address racial and ethnic disparity and inequity?
So just the issue of racial inequities, I think California has been trying to address this for many, many years, but specifically with the pandemic, we know that the impacts of the pandemic has not been equal, and that we're seeing low income families, people of color, that are more severely impacted by the pandemic. So in California, we've done a couple things. And so one of those, we have done a Golden State stimulus, is what it's called. But this is either a $600 or $1,200 payment to low income Californians, similar to the federal stimulus that has gone out. And then also we have expanded some of our tax credits that we know are most beneficial to lower income families of color. So the California Earned Income Tax Credit and the Young Child Tax Credit. So we've expanded and we hope to expand those further in California. So those are just a couple of things that we have done. And I'll stop there because I know we are running short on time. So,
Danette, why don't you finish us up there? What is
Sure.
Nebraska looking at in terms of addressing inequity?
Absolutely. In July of 2020, we did a presentation on data and the disparities of what data was telling us about our communities of color and how it impacted folks getting tested or not getting tested. I will tell you, Ian, that was an eye-opener for all of us, including the governor. And so he immediately told me this is not good for Nebraskans. As you know, in Nebraska, about 7% of our population is Hispanics, 11% is African Americans, and we have Native Americans throughout our state here in Nebraska. And when he saw the data, he said, this is not how Nebraskans should live. So what we immediately did was we developed what was called a multidisciplinary health disparities task force throughout the state with not only health officials, but we also included community-based advocates and providers to sit at the table and to develop some recommendations that we're going to be presenting to the governor at the end of this month. We are working very closely with developing a framework for how we look at equity through an equity lens, and we will be retreating about that this summer, which I'm happy about, with our FQHCs, local public health departments, some community-based agencies in our health systems to look at how race and ethnicity plays into how we develop policies. And are the policies that we're developing, are they forward thinking and at least helping our communities of color move forward? And then finally, from an economic standpoint, we've embarked on a new initiative in Omaha. Omaha, the great state of Nebraska, has a wonderful city called Omaha, Nebraska. And in Omaha, we are looking at economic inclusion. And what that means is that we have a community called the North Omaha community that is predominantly African American and Hispanic. And we are looking at strategies that bring jobs and economic development to that community from both an economic workforce development perspective, but also from a housing, education, thriving communities perspective. And this is something that my peer, Tony Goins, and the governor, we launched just on Tuesday to tell people about the great work that we're going to be doing in that community. I mention that because the focus of it is, number one, build business capacity. Number two, recruit and retain good talent here in Nebraska. and particularly from those communities of color? And number three, how do we create a pathway to wealth? How do we help people who are underserved create job opportunities and create a sense of wealth so that they can live and thrive in their community? So we're real excited here in Nebraska about the work that we're doing around health equities and race and ethnic disparities. And I hope that you'll be calling on us for how we're doing in the next 6 months to a year.
Thank you, Danette. Thank you. Yes, as horrible as the pandemic year has been, I think one of the silver linings is the spotlight that has been shown on racial inequity, and there does seem to be a fair amount of attention being focused on it. I'm going to have to skip over my last question to you all, which was really going to try to get you to talk a little bit about your biggest lessons learned about practices that you'd like to carry forward in the coming year. But let's hold that for now and use the last 10, start off in the next 10 minutes by hearing from the audience. I'd like for us to get some audience questions in and on the table. And if you feel like working in some of your lessons learned into those answers, that'd probably be appropriate too. All right, Bridget, do we have any questions from our audience members?
Sure, we have a few. So I'm going to start with one that I think builds on the question the panelists were just answering. So this questioner is thinking about the disproportionate impacts, negative impacts of COVID on undocumented and mixed status households, and wondering how that factors into states' priorities moving forward. So the question is, are there feasible opportunities to expand benefits for this population?
Anyone like to take a shot at that? Suzanne? Oh, Renita, great.
Sorry.
Please.
I'll be quick so others can also answer. I just wanted to say that in California, I mentioned earlier that we're kind of still in the middle of our budget process, but one of kind of the budget proposals that has been put forward within the state legislature is to expand food assistance programs. So currently in California, there is a program called the California Food Assistance Program that serves individuals who are not eligible for the federal food assistance programs due to various issues, but one of them being immigration status. But the one of the proposals is to expand that for undocumented Californians as well. So that's the first thing that came to mind when I heard the question. So I just wanted to share that. Again, this is just a proposal, so we haven't put forth our final budget yet, but that's one of the things that's being considered for inclusion in the budget.
Very good. Anything additional from Danette or Suzanne, or should we move on to the next question?
Just quickly, I would say, that was, I think, one of our purposes. There were many, but in electing coverage for the optional uninsured COVID-19 testing group. So that's one of the things that we've done. And Nevada does have a large undocumented population, and just really trying to emphasize where services are available and highlighting the great work done by our federally qualified health center partners and making sure that we get, appropriate messaging out, related to vaccine and targeting some of those messages to the immigrant community. I know, there have been some fears related to collecting that type of information. So our state has done a good job of messaging around the vaccination, and that that information wouldn't be used for any sort of immigration purposes. So I think that those are a couple of the things that Nevada has done to try to make sure there's coverage for these critical populations.
Thank you. Why don't we move on to another question? And don't mean to cut you off, Danette. Let's see how many more questions we can get in from the audience.
Sure. So I think this question is primarily targeted to Suzanne, but others might have some input too. How are you planning to deal with the end of the public health emergency and the redeterminations that are coming up to limit disruption of service given high caseloads?
Well, through lots of cooperation and partnership with our sister agency that is also a part of our state's umbrella human services agency. The Division of Healthcare Financing and Policy, which is Nevada Medicaid, doesn't actually do eligibility determinations in Nevada, but certainly has huge implications for our budget. And we've also been working closely with the exchange to try to ensure continuity of coverage and smooth transitions as we do begin working through redetermination. So have just been closely going through the guidance that CMS has issued related to the unwinding of the public health emergency and redeterminations, and working with our partners that more directly determine eligibility in Nevada.
And I would say the same thing in Nebraska. We're beginning to develop a plan about what that's going to look like. My Medicaid director told me that I could expect to see probably a 10% increase in redeterminations. Probably it's going to be bigger than that. But we're already starting to look internally at our resources and who externally we can get to help us with making those decisions. So we're starting to plan that now with the possibility of the pandemic coming to an end.
Very good. Thank you. Okay, we still got a few more minutes to go. Any more questions from the audience?
Sure. It has been touched on a couple of times. I know Danette mentioned at the top of the discussion, talking about public health data. There's a questioner that's interested in improving data coordination and systems across health and human services, so relevant to all of you. And just thinking about whether any of the pending resources, federal resources, are going to be devoted to that. So is there more going on in terms of coordinating eligibility, enrollment, and care management across services?
I can go ahead and answer that. Absolutely. As I said earlier, one of the things that I think a lesson learned from this pandemic is how can we better utilize data, synthesize it, analyze it to better serve Nebraskans across the human service sector. One of the pluses to my job is that all of human services, including public health, reports to me. So I have a plethora of data that I should be able to utilize in a way to help me make better decisions about emergencies that could happen. But you know, public health is known for being preventive. And one of the lessons learned is how do I use my public health data to do some predictive analysis? Not wait for the crisis to happen, but how do I start strengthening my infrastructure with always the thought that a crisis could happen? So here in Nebraska, we are spending a lot of time and a lot of money. And I'm planning to use the federal dollars that I get from the CDC and from some of the other entities to really undergird and strengthen my infrastructure, if possible, with IT solutions that really help me tell the story and predict possible, problems in the future.
Excellent. In a lot of the equity work that we've been doing, we've learned it's quite shocking how much data are not collected that disaggregate by race and ethnicity. So tying things back to the equity issue, I'm sure that's part of your plans as well. I think we've got about a minute and a half maybe to answer one more question. Let's see what other question we have out there that we can answer briefly.
I think this could be brief. This morning, one of our questioners heard there's a high number of individuals not showing up for their second dose of the vaccine if required. Are you seeing that in your state? And I guess I would add, any thoughts on sort of quick responses to that problem?
Suzanne or Renita, do you have a 30-second answer?
I have an anecdotal one that's not really data informed, but I went to get my second dose of the COVID vaccine this week. It was a collaboration between our state's large safety net hospital provider, and they reported that they had seen a large drop off in second doses at that particular site. Again, that's not really statewide or representative, but just a quick anecdotal data point is all I have.
Renita, any final word there?
No, actually, unfortunately, I don't have any kind of data to share on that. So I'm not sure.
It's a big issue that's making a lot of headlines just in the last week or two. Mm-hmm. Okay, well, I do not want to step on Heather's toes and cut into her time. So I just want to thank all three of you. It's been a terrific panel and we learned a lot. The next panel, as Heather will have described, will feature national experts who will really put a lot of what you've been sharing with us into a national context. So Heather, back to you. Thanks.
All right, thank you. That panel was excellent, really gave us a lot of ground. They covered a lot of grounds and give us a lot of food for thought for this next panel. So as Ian said, we now turn to our panel of experts who can provide a national perspective. Everyone on this panel is a representative of a national organization that represents state officials and program administrators. So as I introduce you, please turn your cameras on. Ann Flagg is a senior director at the American Public Human Services Association, which represents state and local health and human service agencies. And Ann in particular oversees policy and practice work in child welfare, child care, economic assistance, workforce, and family supporting systems. Welcome, Ann. Stacy Mazer is a senior staff associate with the National Association of State Budget Officers, where she is responsible for monitoring and analyzing the impact of federal health and Medicaid decisions on states, as well as tracking human and social service developments within states and monitoring overall state fiscal conditions. Welcome, Stacy. Matt Salo is Executive Director of the National Association of Medicaid Directors, which represents the nation's state and territorial Medicaid directors. So welcome, Matt. Let's start by reflecting on what we just heard from the state panel, starting with their concerns early in the pandemic. They talked about some vulnerabilities and strengths that the pandemic exposed. Can you help us put their comments in context? And how does what we heard from the first panel compare with what you might be hearing from your other members across the country? And let's start with you.
Sure, thanks. Well, first of all, it's a real privilege to join this incredible panel today. Thanks so much for having us. So yes to everything Danette said, bolded, underlined, highlighted. But before getting into that, I just do want to take one step back and just take a moment to acknowledge all the state and local public human services leaders, health leaders, and their ability to respond so nimbly to ensure the safety and well-being, both of the communities that they serve, as well as the public servants and staff that make the programs we're discussing today continue to work even in the craziest of circumstances for the families and communities that have needed them most. When we think about state agencies, the staff within them are themselves negotiating or have negotiated over this last year, school closures and working from home, illness and job losses within their own families. And so for me, it's just important to acknowledge the work of those public servants over this last year. In thinking about the very early days of the public health emergency, there was really no playbook for how you handled mass closures of public buildings. There was no national framework around determining essential personnel under these circumstances. As Danette described, there were shortages of PPE, even laptops, but at the core, state HHS leaders, it was a commitment to ensuring efficient delivery of economic and social supports, medical and healthcare related supports to families and communities. So in order to meet the moment, states moved at incredibly lightning speed to implement new staffing structures, equip staff with necessary technology to ensure continuity of operations, engage networks of partners to ensure clear communications with service participants and providers. And it required incredible work to advance emergency procurements for equipment, virtual tools, technologies, which under normal circumstances would have otherwise taken months or years. As a system, the public human services agencies advanced leaps and bounds, innovating in ways that would have otherwise felt just completely unimaginable. And from a policy and service delivery perspective, I just also want to acknowledge the determination of state and local leaders in processing and quickly operationalizing the many pieces of policy guidance that came through different agencies with different requirements, different timelines. Some changes needed waivers, other state plan amendments, others still needed state regulatory and statutory changes. It was an incredibly complex policy matrix to wade through, but state and local leaders, leaned on one another, federal partners, and thought leaders like Urban and others to really navigate and ensure continuity of services for families. And just one quick thing that I think was really telling and a very important lesson learned, sort of framing up, comments a little bit later. In those early days, exactly as Secretary Smith or Danette described, there were just numerous policy actions that were coming in that were not always consistent across programs. So certain things, like, for example, pandemic unemployment was treated differently in Medicaid than it was in the SNAP program. And all of this was reliant on quickly reprogramming, in some cases really ancient technology, in order to get those benefits out the door quickly. So that was really sort of the all-consuming piece of the early days, in addition to all of the issues Danette so perfectly laid out.
Great. And Stacy, thinking about the budget context, how much variation did you see in how the pandemic was affecting state budgets? And were there certain health or human service programs that felt at greatest risk?
Well, thank you once again for the invitation and being with great colleagues here. Yeah, there were differences across states. I mean, as Suzanne mentioned, tourism-based economies were particularly vulnerable, oil-based. It really depended on your tax structure, industry, severity of the virus. So there were those differences. I think initially, as Renita was talking about, there was the comparison of the days of the Great Recession. What kind of impact would we see fiscally? And that was sort of the benchmark, essentially, a year ago. It was, states lost about 11.6% of general fund revenue over 2 years. So that was sort of the comparison. And the thought initially was, wow, it's going to be double that. So there was, a lot of uncertainty. And, as Anne was talking about, and I know Matt will talk about this too, this sort of sharing information across members, our membership, as well as other organizations, was really, really key as far as, sort of the real-time information about what was happening that was so, no one had gone through it before. In terms of the health and human service programs, I'd say we talked a lot about Medicaid, being such a significant part of the state budget. It's sort of the elephant in the room all the time in terms of the, fiscal implications there. And it was extremely important to have the additional federal funds. That was, the additional FMAP tied to the public health emergency. So there were many discussions all year of, would the public health emergency be renewed? It was a 90-day basis. It's really hard to plan on that kind of basis. So there was so much uncertainty about the funding, that aspect. And then the program, of course, the vulnerable providers and all the things, we heard about in the first session, as well as just what kind of enrollment would we see? We were going to see some of the enrollment impact from the continuous eligibility requirements, plus the impact from unemployment. As Suzanne mentioned, they saw a really huge spike in Nevada. I mean, it did differ across states. So there was a lot of focus on those issues.
Okay, well, that's a segue to Matt. What did you see nationally across Medicaid programs in terms of the response to the pandemic, strengths and weaknesses it might have exposed?
Yeah, so a couple things. I mean, I think that, if we're thinking back to March, to June, in the summer of last year, we were kind of thinking about the world, or Medicaid directors were thinking about the world through three lenses. The pandemic, which was kind of all consuming, the economic downturn, which, much to Stacy's point, was we're kind of in it, we think. Is it going to look like 2009 or not, better or worse? We don't know, but we're on this ride. There's no getting off. And then, to a point that I know that was discussed in the previous panel, was the long-standing and really challenging racial and ethnic disparities and inequities inherent in the system. And by system, I mean not just Medicaid, because it is the broader healthcare system. And let's face it, it's not just the healthcare system. It's kind of endemic to society at large. So everything was being looked at through a combination of one of those three lenses. Now, I think the partial good news is that, and whether it's because of the resiliency of some state economies or the definite benefit of the federal stimulus efforts, the economic downturn has not hit all states. Nevada, yes, it's bad. Other states, it is bad, but other states are seeing a surplus. And so it's a real mixed bag in terms of what's out there. And I think, it was interesting to kind of think about the pandemic, though, because on some level we could look at it and say, this is just game changing. We've never had anything like this happen in this country ever before. And I think that is, not since the Spanish flu in 1917. But on some level, we did have some experience of trying to manage through crisis, because Medicaid has, through much of its, much of the past 25 years where I've been working in it, and much of its history, Medicaid has really served as kind of the backbone of the US crisis response system to any kind of big emergency. So whether it's something that's more localized or regional, hurricanes Katrina or Rita, natural disasters, man-made disasters like 9/11 or other things, Medicaid and Medicaid coverage and Medicaid services have for a long time played a really, really critical role in kind of backstopping not just the US healthcare system, but US society writ large in an emergency like this. So there was a little bit of a playbook, and states that had been through, hurricane after hurricane, like Florida and Louisiana, were like, all right, we think we got the cadence of this down. It's on steroids, but we know. And being able to bring them together with the other 50 states, the other 56 total states and territories, to say, hey, you might not be used to dealing with emergency waivers, but we are, and here's how we can help you kind of think through it. So that I think that has been really, really meaningful. And I think just the one other point, and I know there's lots more to talk about, but as we thought about the pandemic, the two biggest challenges were kind of polar opposites in how the pandemic has impacted the healthcare system. The first of which is, all of those healthcare providers and people who are kind of like on the front line of the surge. Nursing homes and other long-term care facilities where so much of the mortality was happening in early March. Hospitals where it's been so apparent what was happening there with the lack of ICU space and ventilators and respirators and everything else, and the challenges of dealing with a workforce that didn't have PPE, that was burning out on triple overtime shifts, that were getting sick themselves. How could Medicaid support those critical parts of the healthcare infrastructure while at the same time worrying about everybody else? So all of the clinics, all of the smaller mom and pop, HCBS providers, dentists, pediatricians, mental health, behavioral health providers, where if people aren't experiencing a healthcare crisis, they're not going to go to a healthcare provider in a pandemic. And so, absent any kind of, intervention, huge swaths of the healthcare infrastructure at risk of just going bankrupt and not kind of being able to withstand that anti-surge and to be able to bounce back, because we are going to need those guys more than ever once we finally kind of get across the finishing line of, we're vaccinated and we're getting back to normal, because there's going to be so much pent up need from people who have foregone healthcare visits, whether that be mental health, behavioral health. I mean, kids who have gone without seeing a pediatrician for years now. we're going to need a huge capacity to rebound when the system is ready, and we got to keep that in mind as well.
Yeah. Okay. Thanks. That gives us a lot to think about for the context. Looking at where we are now, let's discuss how the recent influx of these unprecedented federal relief dollars will affect safety net programs. And Stacy, Renita mentioned the challenge of balancing one-time spending with future spending. And as states are looking across their entire budgets, how will states spend these large but temporary federal funds? And to what extent do you think these will they ripple through state funding and budgets, affecting existing funding as well as the new funding?
Probably all of the above. I think it's probably too early to tell. It just sort of the funds are, they're still waiting for guidance. That's one piece of it. And as Renita mentioned, the sort of balancing that these are significant amounts. They do have, a couple years, but not forever. So wanting to make sure that they're used in the best way. And there's also a lot more sort of decision makers involved than we saw during, the CARES Act. Some of that funding was really sort of very short term. There's legislative involvement, certainly the governors, the, various other entities. Some are looking at it as sort of, trying to do a listening tour. I mean, there's a lot more sort of actors involved in terms of making decisions. Some states did wrap up their sessions and did appropriate some of these amounts, some partial, some total. I'd say that's the minority. A lot of states are still in legislative sessions now. Some adjourned and said, we'll look at it later. And waiting for the Treasury guidance is a big issue, and that should be forthcoming. And there's also talk about it being very transformative. This could really be a game changer. So, looking very broadly within your state, both with, local jurisdictions, various programs, hear a lot about capital. Broadband is probably the #1 issue cited. Health and human services, help for providers, help for education. We heard about the food banks. I think we're going to see a really array of programs. So we're watching it closely, but it's evolving.
Okay, great. And Anne, one of the things that we heard during the interviews that we were doing for these reports was some concern about the state and local capacity. These funds are needed, they are welcome, but the state and local offices in some places may be pretty small and not used to dealing with the scale of funding. Do you have a sense of the extent to which state and local capacity to administer and distribute the funds is a challenge, and how states might address it?
Yeah, I think it's a great question. And I think it's sort of two-part. One, everything Stacy just said, I have the great pleasure of having her given all the right answers before my turn. And so I think, in terms of capacity, some of it is limited by what your legislation or your governor's, your executive branch defines, right? So I think that is sort of one piece of it, understanding, can there be additional personnel assigned to effectuate these programs? And I think the other piece of it, Stacy certainly touched on the trickling of guidance. So folks uncertain of, how to best spend these dollars, what's allowable. So, some holding back until there is complete clarity around how the dollars can be used moving forward. And just the last thing I'll note is, there were limitations around administrative purposes in some of these funding streams. So, you saw something like childcare with just an unbelievable infusion of dollars, but a very limited percentage of that being allowable for administrative, including increased staffing. So 5 times the program activity and the same number of staff.
Okay, great. And Matt, quickly to you on Medicaid. How will the influx of dollars ripple through and affect Medicaid programs?
I think there's 2 things. I mean, one is how, the utility of the 6.2 percentage point increase in the federal match that's been flowing for about a year now and will flow for another year. The second is that, okay, so we've got the American Rescue Plan that's been passed, where you've got, billions and billions of dollars of new money, some of which, like this 10% increase in the federal match for HCBS services, as Stacy alluded to, it's for 1 year. And that year started a month ago, and there's no guidance. And I know, we'll get there, but it's really going to create a challenge for, and the first panel discussed this, really, really well. You got to balance being able to spend something quickly and spend something meaningfully and sustainably. And I think, at least in the HCBS space, without any further guidance that kind of gives us the ability, which we're advocating for, to be more thoughtful about those dollars, to take a longer horizon than just the next 11 months, to build on things, then honestly, what you're going to see is just probably like a one-time rate increase, which might be really important in the short term. You can call it like a COVID bump. But as we've seen from things in the past, like the primary care physician payment bump in the Affordable Care Act, when you build things in that are really, really short term like that, they're just not sustainable. So, we're gonna have to be more thoughtful about that. And then it's also, I'll be honest, it's really kind of confusing trying to figure out, well, how are we going to spend that money now? How are we going to plan that out? How are we going to make that sustainable? And at the same time, we're talking to congressional staff who are like, no, we've got $400 billion more dollars in HCBS spending that we want to push out. And how do you want to spend that? And it's like, I can't even begin to answer that until we know how we're going to spend what's already on our plates now. So trying to figure out the balance between all of these moving pieces is a bit of a challenge, but it's a good challenge.
Okay, so we have already, it's only 8 minutes that we go to audience Q&A. So I'm going to ask a final question for each of you. That's kind of a big one, but what lessons did the past year teach us, and what opportunities did these illuminate for continuing the changes that were made during the pandemic, reimagining the programs, especially in ways that address the racial and ethnic disparities and economic inequality, and just preparing for an uncertain future? So lessons learned. Anne, can you start us off?
Sure. So I think this year reinforced that no single sector can solve the needs of communities amidst an emergency. And as we move into recovery and resilience, requires schools and human services to work together to ensure nutrition for school-age kids. Public health can build community health workers to provide immediate triage around public health concerns, but also ensure connections with social and income supports, right? So we're hopeful that policy can move toward a more integrated or allow for more integrated approaches to more comprehensive services as we move forward, and really think about creating greater consistency across eligibility determination processes to sort of rationalize the rules, across all of the income and health supports programs. And I think most importantly, this crisis has just really laid bare what social determinants means for all of us. It revealed how poverty, racism, workforce inequities, lack of broadband, and all of those things are so inextricably linked to the health outcomes, as we saw demonstrated in disproportionate infection and mortality rates across the country. So we hope as we get to the other side of this, we can start to think about investing in those greater investment in those primary prevention tools that improve, that we all know improve long-term health outcomes and can lead to greater both economic and health equity.
Okay, great. And Matt, what lessons did the past year teach Medicaid directors? What are the big opportunities in Medicaid?
Yeah, so we kind of took we took or are taking a very purposeful long look at that question. And we're actually doing it through a little bit of a process that we're calling Medicaid Forward, where we identified 3 major areas where Medicaid pre-pandemic has a really significant role in the healthcare system. And that's behavioral health, children's health, and long-term services and supports. And Medicaid does a lot of things in a lot of areas, but those 3 areas also were particularly heavily impacted by the pandemic in very, very unique ways that challenged us at our core to be able to maintain the strength of the program moving forward. So what we are doing right now is sort of chunking those issues out, behavioral health, children's health, and long-term services and supports, and saying, what did we learn from how the pandemic has laid bare some of our vulnerabilities, and how do we strengthen those pillars so for that the next pandemic or the next who knows what the next thing is, we're gonna be stronger. And it's really designed, it's not really designed to be a list of federal asks. It's a list of, here are things that can be done at the state level with a spectrum of, here's a small impact thing that you could probably do tomorrow. And here's a big impact thing that will, let's face it, take a couple years and a lot of coalition building to get to. But that all of these things are possible, and to kind of think about, whether your state is Arizona or California, Nebraska, Nevada, whatever, understand where you are now, and then you can kind of figure out what do you need, what could be the most impactful thing that you can do to reinforce and to strengthen the system. So our behavioral health work is already out, it's public. We're in the midst of finalizing children's health, and we're hoping to do our LTSS piece later on this summer. So that's a long non-answer to an important question.
Okay, well, we will watch for those pieces. Stacey, you I think at the final word on this question. What lessons did the past year? What were the lessons for the last year for budget directors in the social safety net?
I think a high degree of tolerance for uncertainty, just what we've all gone through. And I think getting out of the silo, we talked about the sort of interplay between programs, seeing how it all sort of works together, the vulnerabilities we saw with individuals. And I think the communication was so important. I mean, the sort of plus side of what we experienced this year was, we had more member calls, budget directors, budget offices, just sort of exchanging information in real time on what they were seeing, and amongst our colleagues here. I mean, it was invaluable, to have that sort of exchange of information. And, I think it got us out of our silos in so many ways within programs within the state and within our sort of associations and organizations. In terms of a budget perspective, I'd say that states generally were in good fiscal shape going into this. And we had many discussions about rainy day funds and reserves, what happened during the Great Recession. I mean, we had sessions about this all the time at our meetings, strategies to build them up. In fact, the last in-person meeting, we talked about this, preparing for the next recession when no one else was talking about it. And so I think generally states were in a pretty strong fiscal condition with sort of good reserves. And so that was really important. I think they will be replenishing them and recognizing how important they are over the long run, but certainly no one anticipated a recession with a pandemic, so.
Great, yes, that was certainly an added wrinkle.
Right.
We do have one more minute until questions. So just quickly looking back, and you give me a 30-second answer or less. Is there anything that surprises you about how things happened for the states in our panel or others across the country?
I guess real quickly, I'd say that one thing the pandemic has taught us is that Medicaid, as a $600 billion a year program covering 1 in 5 Americans, can move really quickly when it needs to. And there was just this absolute flurry of emergency waivers and all sorts of activity in those first couple of months. And I really got to give credit to our federal partners at the Center for Medicaid and CHIP Services for working with us to get enormously big things done very quickly. You can get things done quickly when the rules kind of don't matter. But at some point, the rules are going to matter again, and things are going to slow down again. And the auditors are going to come in and rethink all this stuff, and we're going to have to take a breath. But we can do it.
Okay. Stacy?
No, I would just say, we talked a little bit about that, the circumstances were not as dire from sort of a budget perspective. And, we saw the additional federal aid packages, the fact that, higher income people could work at home and still pay taxes, online sales, the Supreme Court decision was very, very timely a couple of years ago. And so for all those reasons, we sort of, as the year progressed, I think the feeling was, this is not as bad. Not that it is not bad, and there's certainly revenue loss, extremely expensive, additional expenses for delivering services and complexities. But I say that was the biggest surprise from a year ago when, it just looked like it was just going to be a crater.
Okay, great. Ian, any surprises from you? And then we'll go to Q&A.
I think just how quickly innovations and total system operational transformation occurred in ways that, having come from a state agency, I never would have thought would be possible in such a short period of time. Just incredible advancement.
Okay, great. Thank you all for answering my questions. And now we will turn to the audience questions. Emmy, what questions do we have?
We have a first one here that says, what types of administrative changes could federal agencies put in place that would help them better respond to states' needs during an emergency? And did those agencies have the tools and flexibilities they needed to work effectively with states?
I think there's two things. One is there's administrative flexibilities. And I think what we've seen from the pandemic is that those worked. We had 50 plus states, not just one or two in a hurricane, but 50 plus states who were able to get things done really quickly with a willing dance partner at CMS. So I don't know how much new needs to happen there in the big picture. I think the other piece, though, that is more than just administrative, but I think is clearly necessary, is we got to think about enshrining some kind of permanent counter-cyclical funding into statute. Because, the last 3 economic downturns that I've been through, and I know Stacy's been through them too, we've had to fight tooth and nail, and there's been an enormous amount of uncertainty about who and what and why and how long to get federal help. And it has eventually come, but we shouldn't have to be having that fight every time there is a big emergency. And so I think there needs to be some kind of, I don't know, MacPac's got some really thoughtful stuff out there. There needs to be some kind of counter-cyclical funding bump to help states out through emergencies like this, when, let's face it, so much of the entire engine of Medicaid is driven by state general revenues and state economies and the state capacity to do these things. And that's what hurts the most in a downturn or an emergency like this.
Stacy, Andrew, either of you want to take this question?
I would just comment, and I think with the federal agencies had a huge job for them as well. Just this sort of guidance. I know that was always, and Anne referenced that as well, the just either changing guidance or waiting for it. And I'm not sure how much could be done with how many new programs and changes. It was such a huge task, but that was something that I think there was a lot of work spent on interpreting guidance, figuring out you did something and now it's different. Any kind of clarity on that is extremely helpful.
Yeah, I think the only thing I'll add is the importance of during this time really capturing what worked, what didn't work, and codifying in some pandemic preparedness planning. I mean, as Matt said, we've had hurricanes, we've had fires, we've had all kinds of emergencies, but never anything quite like this that had the same types of implications of just mass closures and at such a scale. So, codifying that learning into broader emergency preparedness planning, I think, is one of the most important things that we can do as we move out of this, out of the emergency phase.
Great. Emmy, what else have we got?
We have a Medicaid specific one. It says, do states feel that they overpaid Medicaid managed care plans in light of beneficiaries' reluctance to seek care to avoid COVID exposure risks? And if so, are you hearing that states are thinking about ways to recover those overpayments?
Yeah, yes. And I think that, well, yes and no. So yes, I think we have seen over the past year that, and in large part due to massively reduced utilization, a lot of managed care plans with their capitation rates set years before did pretty well. And if you kind of look at it and say, you're doing really well in an emergency, it can kind of rub you the wrong way and say, we got to do something about that. Now, I think the ideal situation is that any plan out there that got overpaid this year, I think the clear expectation from states is, yeah, but whatever you may have made in excess profit this year, you are going to be reinvesting that into the system next year when that other surge of pent-up demand comes back, and people are going to be coming out of the woodwork to see providers. You're going to have to use that money to increase rates. You're going to have to use that money to support provider networks and other things. Find whatever it is, you're going to have to think about the world and not just, well, we did good this year, yay, and let's, bonuses for everybody. And next year is different. You got to think about it in that continuity. And I think that if that becomes a problem, then I think you will see action taken. And actually, I know what some states are doing is they're actually looking at the per member per month payment rates to plans and saying, as enrollment has ticked up and up and up and up because of the maintenance of effort, one thing that some states are doing is saying, you know what, this is not necessarily new people coming in who are sick and need Medicaid. A lot of these people are kind of this churn population who kind of normally kind of cycle on and off Medicaid and only really interact with the system when they need services. But for the most part, they're healthy and not using services. So they're actually redetermining the per member per month rates to knock them down a peg because yes, there are more people, but on average, the case mix is now much healthier relatively. So there's a number of things I think you can do to kind of make that, excess profit in the past year balance out in a meaningful way.
Okay, I think we have 1 minute left. Emmy, is there a really quick question?
Yes, this one says, there's a lot of discussion, including here today, about cross-departmental collaborations, data sharing, service delivery, etc. What are the chances that further alignment will occur post-pandemic?
And I think that one's for you, if you can answer it very quickly, if you want to.
Yeah, I do think that there is tremendous opportunity post-pandemic. I think that, as Danette said, there's going to be quite a bit of funding that's going to come through more on the public health side, but figuring out how to map through the social determinants, through Medicaid, through human services. I think there's a tremendous opportunity as we move into recovery and resilience.
Okay, great. Well, we are at time. Thank you all of the panelists, and Thank you all in our audience for your good questions and for spending the afternoon with us. Have a good afternoon, everybody.
Thank you. Thanks.